So one very important point is that we are looking to correct the corneal astigmatism, not the refractive astigmatism.
Yeah.
So if the patient is wearing 2.5 diopter of cylinder of glasses, but his corneal astigmatism is only 1.5, forget about the refractive part. Whatever glasses he's wearing, don't get confused that patient is having cylinder of 2.5, he's wearing glasses. So we are not looking for refractive astigmatism, we are just correcting the corneal astigmatism. I think that's very important, you know.
Yeah.
Then secondly, the table which Dr. Rajesh showed, that if you look at the toric IOL, so there are two power written on the lens box, you know. One is the at IOL plane, that if suppose at the IOL plane is 1.5, so we get the correction of 1 diopter at the corneal plane. Now these manufacturers, they all use the a fixed ratio of 1.46 to correct between, because at IOL plane and at the corneal plane, we get the different power. So that's how this table reads like. So once we have with us the and one more thing I'd like to highlight is okay, thank you very much, Dr. Rajesh. One very important, can I have the pointer please? Is that whenever you are doing your biometry, it's always better if you use the optical biometers. If not optical, then immersion biometry, not contact biometry. And it's always better to rehearse, you know, before starting toric IOLs in your normal patients. So it's not that when you have a patient of toric IOL, you take them for this, because this marking of the IOLs, then putting the IOL at particular axis, so it all can be done in any normal patient. So once you do this in 10, 12, 15 patients, you get used to all these things. So I'll take you to the procedure that once we have the desired axis where we want to implant the IOL, how to go about it.
Sorry, man.
Yeah.
Just don't take the refractive astigmatism at all.
No.
Even though there is
No.
a lot of discrepancy.
No, forget about refract, because refractive astigmatism is, you know, the internal lenticular component also comes there. So we are just correcting the corneal astigmatism. So this is that's how the Hoya online calculator looks like. So now, so once you have the chart with you that you have to implant the particular IOL at this steep axis. So first we mark the reference axis on the cornea, that is the 0 and 180 degree. So there are various instruments which can be used to mark. This is the ASICO bubble marker. It has a bubble there in between, and these 3 prongs are there. So you just put the ink here on this prong, and this bubble marker, it tells you whether you are at the perfect horizontal level or not. So you can mark the 0, 180 and the 6 o'clock. And this is the electronic toric marker, which has a central green light. So if you are not horizontal, it gives either orange or the red beep, red light also and beep. So you can mark directly also the desired axis with this. But the technique which I like most is the marking at the slit lamp. So before dilating the pupil, take the patient on the slit lamp, rotate the slit beam, make it horizontal, and then use a 26 gauge needle to scratch the epithelium. So what happens that if you directly stain this with the ink, your ink mark can fade away by the time you take patient in OT. So if you have these scratch marks, they won't go. So I'm scratching the epithelium and then putting the ink on the tip of 26 gauge needle and then staining it. So you get very thin stain, thin marks, as well as these scratches, they don't go away, even if your ink fades away. So after marking this 0 and 180 degree, now we come to the intraoperative axis marking. This is the Mendes degree gauge. So these are the 2 grooves here and that side. So we align them to 0 and 180 degree. Again, I use a 26 gauge needle to mark the desired axis. This is somewhere around 83 degrees. So I put a very thin mark here and put a very thin mark on the other side. Remember that your cornea has to be dry so that you can get a better stain. And then I mark my incision also. It's somewhere around 20 degrees here. So now you have two thin marks. And this is the meridian marker, Boris meridian marker. So you put the ink on this and then join these two thin marks. So this is our steep axis where we have to align the toric IOL. All the toric IOLs have the laser marks on their posterior surface, and these marks, they signify the least power. So these marks have to be aligned with the steep axis of the cornea. So now coming to the IOL implantation. So once you finish your irrigation aspiration, this is the Hoya preloaded IOL. You just need to put viscoelastic here. The second step is to take off this lock. It's a screwing type of injector, and it goes through 2.2 millimeter incision. So you go in, and it has a beautiful uniplanar delivery in the eye. Now, this IOL is implanted in capsular bag. You can see these two toric IOL marks. It's always essential to go behind the IOL optic and remove the OVD, because the residual OVD may cause the post-operative rotation of the IOL. Okay, so that is how you implant the IOL. This is another case. You can see. So I usually don't use OVD to implant the IOL. That is hydroimplantation technique. This is my irrigation cannula is in the capsular in the eye. It maintains the capsular bag and the anterior chamber. Your capsular axis has to be of 5.25 millimeter perfect size, so that it covers the IOL optic completely. This hydroimplantation technique is very useful for toric IOLs. This technique was published in JCRS 2010. So this is the axis of toric IOL. And using the irrigation cannula and the Q-Glens hook, I rotate the IOL to the desired axis. You should wait so that the both the haptics of the IOL, they expand completely. See, I'm rotating the IOL and getting it to the final desired axis. So this is the final outcome. There is another technique to mark the anterior capsule, what is called as the porthole technique. What I do once I implant the IOL in the capsular bag, rotate the IOL to the steep axis, and then in Artley phaco machine, I don't have any financial interest in that, they have the radio frequency capsulotomy probe. See, the IOL is well aligned. So I use that radio frequency probe to make very small marks on the holes in the anterior capsule on the outermost toric mark, one here and one here, so that in post-operative period, as soon as you dilate the pupil, you can see whether they are well aligned or not. I'll show you the post-operative photograph. See, I put OVD. This is the radio frequency capsulotomy probe, which comes with the Artley phaco machine. I go over the outermost mark and make very tiny hole there. Then I go on the other side as well and make very tiny hole there. So I'll show you the slit lamp photograph of these portholes. If we can make out, there is one hole here and there is one tiny hole here. So just dilating the pupil, you can see the rotational stability of the eye hole. You don't need any software or anything to make out.